Okay, guys, so now we're going to go over chapter 23 and 24. They're both in the same recording, so make sure that you get all of the content for both chapters. Chapter 23, we're going to talk about care of the newborn and the family after delivery. So a few things, immediate care after birth. So our number one thing that we need to do is establish effective respirations. We have to ensure that that baby is breathing well and breathing on its own. Okay. They also suction nasal and oral secretions. We want to dry and stimulate. We want to make sure that we get all the amniotic fluid and everything else off of that baby so that they're dry. Because remember, in the previous chapter, we talked about how easily babies can become cold. The last thing we want is for them to be covered in a fluid that's going to continue to make them cold and lose heat. Okay, so we dry and stimulate. Whenever I'm talking about stimulating, it's simply when they're drying that baby, that stimulation from them rubbing the blanket to get everything off is going to help stimulate that baby. Okay. And then skin to skin with the mother. Sometimes they do this immediately after delivery. Other moms want them to go to the radiant warmer in the room for just a minute and get really cleaned up and then lay on mom. So just realize that that's going to be different for each patient, but it is important to help with bonding for them to do skin to skin. APGAR scoring, this is going to be important for you guys to understand APGAR scores and know what's good and what's bad. So if you see a test question that tells you a baby APGAR 8, you need to know is that good or is that bad? So APGARs are done at 1 and 5 minutes. So whenever you see this documented, you may see like, let's say 4 and 8. Okay, so that means at 1 minute that baby only APGARed 4, but at 5 minutes they APGARed 8. Okay, APGARs just tell us how this baby is transitioning to extrauterine life. How well are they surviving outside of this uterus? Okay, it looks at heart rate, respiratory effort, muscle tone, reflex irritability, and their generalized skin color. All of this information is in table 23.2 on page 555. So the example I'm going to give you guys is going to be a good baby. Okay, so in this PowerPoint right here, this is all a great baby. Each of these is going to get 2 points. Okay, so a good baby has a heart rate greater than 100, a good cry, their muscle tone is well flexed, their reflex irritability, they cry, and then generalized skin color, they're completely pink. Okay, so with APGARs, each of these areas is worth a point. Okay, you can either have 0 points, 1 point, or 2 points. Okay, so with APGARs, you can be somewhere in the middle. So we can have odd numbers with an APGAR. Okay, so say that this baby had everything except for the heart rate was only 90. That's going to deduct a point, so this baby's APGAR would then be a 9. Okay, a bad baby would have absent heart rate, no respiratory effort, they may be flaccid, no response to any reflexes, and they can be blue or pale in color. Okay, this would be obviously very, very bad. So normal respiratory rate for a newborn is going to be anywhere from 30 to 50. Okay, but remember, we talked about the periods of reactivity, and in those first 2 hours, the respiratory rate may be a little bit higher. Okay. Blood pressures, as we discussed, they're not routinely taken unless we are suspecting some cardiac problems. The blood pressure is going to be high after delivery. It'll decrease and then come back up, so it's really not a reliable measurement. Okay. Temperature is done axillary in newborns. This is something that's different at each hospital. I know BSA does not do rectal temps in the nursery, but they do in pediatrics. So it's very dependent upon the policies and the protocols at the facility that you're at. But for the sake of my portion of the newborn stuff, we only do axillary temperatures. Like we just said, we want to do the heart rate and respiratory rate first to make sure that that baby is not crying when we take that temperature. Fontanelles, we assess them. We want to make sure that they're flat, they're not bulging, okay, or they're not sunken in. Jaundice, this is assessed for each time that we look at that baby. And remember, we discussed that signs of jaundice in the first 24 hours are a sign of a pathologic issue. We have something major going on that's causing them to jaundice that early on. And again, we're going to talk about that when we get to chapter 25 in just a little bit. Gestational age assessment. So when we're looking at this, we're looking at how far in gestation that baby was at birth. Okay, this is called the Ballard score. It assesses 6 external physical and 6 neuromuscular signs. And this is also in your book. It's figure 23.2 on page 558. I'm not personally going to test you on this, but this is something that you may see either on NCLEX or possibly even on your HESI exam. In my experience, what I've seen, if you do have a question about it, you are given this particular picture to judge and make your score based off of it. And you need to know that the higher the score, the greater the gestational age. Okay, so just briefly look over this in your book and be familiar with the scoring. We would use this if, say, a mom never got prenatal care, and so we don't know the gestational age of this baby. So we can score the baby in each of these areas, and it'll tell us how mature in weeks or gestation that that infant is when they are born. Okay, this is used a lot in the NICU. Gestational age and birth weight. So these are just some terms that you need to be familiar with. Know that appropriate for gestational age is going to be between the 10th and the 90th percentile on their weight. So these babies grow at a normal rate regardless of how long their gestation is. Okay. Large for gestational age. These babies are going to be above the 90th percentile in weight, so they're growing faster during their fetal life. And then small for gestational age is below the 10th percent, so they have some sort of growth restriction during their fetal life. Low birth weight is going to be classified as anything less than 2,500 grams, whereas very low birth weight is less than 1,500 grams. Okay, don't memorize those exact numbers, but just know that some babies, especially in the NICU, are weighed in grams because of how small they are. And those are classifications to say we have a higher risk baby if they're that small. In your notes, it also goes over early term infants, and stuff like that. I'm not going to review that again. We've discussed that. Make sure that you know your dates for gestation and how long the length of gestation and pregnancy should last. Okay. This says immediate interventions. This is how your book has it charted. But that doesn't necessarily mean that everything is done as soon as that baby is born. But these are some things that we're going to do while that baby is in the nursery pretty soon after delivery and definitely before discharge. Okay, so airway maintenance is our number one thing that we discussed about once we make sure that that baby is breathing. We also need to suction with the bulb syringe, especially if that baby was born by C-section, because we've discussed that that vaginal delivery gives that extra push to push any fluid out of that baby's lungs. Whereas with a C-section, we don't have that option. Okay, so the gravity or the force of that delivery does not remove any fluid from the baby's lungs. So as a nurse, we need to ensure that we're suctioning with a bulb syringe to maintain that airway. Okay, every baby should have one of these in their cribs, and the parents should be aware of how to use it as well. Body temperature maintenance, we want to do early skin-to-skin contact. We place that baby bare to the mother's chest, and we want to make sure that we still cover that baby with a warm blanket over the top of mom, okay? We don't want them to just be out there laying on top of mom because we're still going to be losing all of our heat. Sometimes we place these babies under the radiant warmers to help control their temperature. That's done in the nursery. Okay. Eye prophylaxis, this is done to prevent passage of sexually transmitted bacteria during delivery through the birth canal. We use erythromycin ointment. This is typically given within the first hour of birth. And it's very important because if an infection is passed to the infant, it can lead to blindness. So we need to ensure that we're treating that baby. Whether the mom has a history of an STD or not, we still need to be treating it. And this is mandated by law. Vitamin K prophylaxis, we've touched on this a few times. Low levels of vitamin K at birth, and those babies lack the normal intestinal flora to synthesize the vitamin K. So we give it intramuscularly to prevent that deficiency and to prevent hemorrhage in the newborn. And then the last one is hepatitis B. The advisory committee for immunization recommends that within 24 hours of birth that we're giving this. If mom is infected, then we need to be giving it even sooner. Okay, and it is, again, the law for hepatitis B to be given to all newborns. So with hyperbilirubinemia, we're taking it a step further. Okay, these are higher levels of unconjugated bilirubin. And this is typically going to occur greater than 24 hours after birth. So it's very important that these parents know the signs and symptoms that they need to be watching for to ensure that maybe they're discharged by 24 hours and they're home when this happens. Okay. So with hyperbilirubinemia, that TCB that we talked about, the transcutaneous bilirubin, is going to be greater than 12. So very high. Okay. The levels peak 3 to 5 days. They'll resolve after a week or two. To assess for any jaundice, you know that we press over that bony area, and if we see that yellow color to their skin, they have some levels of jaundice. Okay, but with hyperbilirubinemia, those levels are extremely high. Okay, we need to take care of that. So the first way to take care of it is, number one, we're going to try to encourage early feedings. Okay, promote that feeding to ensure that that baby is having stools. However, if those levels continue to accumulate, we're going to have to do some more interventions. So the number one thing that we're going to do that I want you guys to understand is phototherapy. Okay, this is when those babies are placed under the Billy lights. Okay, some of you guys may have seen this. It's the most common treatment. So the light energy changes the shape and structure of the unconjugated bilirubin, so it allows it to form in a way that is excretable by urine and stool. Okay, we place those babies under those Billy lights in a diaper only, and then we also assess that temperature and monitor for insoluble water loss. Because remember, those babies have a hard time, they can't sweat, but they also have a large body surface area. And so we have to ensure that they're not having insoluble water loss underneath those lights. Okay, and then we're just going to continue to monitor that baby's bilirubin levels. Okay, there are more interventions if it was continuing to get worse, but that's our number one thing that I want you guys to focus on, is just the phototherapy. Okay. Hypoglycemia, so glucose levels are not routinely assessed. Just because the baby is eating and we don't see any signs, so we don't just routinely assess glucose on newborns. Okay. The low side, or hypoglycemia, for a newborn is around 40 to 45. Okay. Remember, on your prep, if a patient has that, we don't automatically treat. We have to get a serum blood draw first to ensure that those are the correct numbers. Okay. Some risk factors for that baby becoming hypoglycemic is preterm, small for gestational age, or large for gestational age, if they had a diabetic mother, or a low birth weight. Okay. Some signs and symptoms that we might see with hypoglycemia are going to be jitteriness, lethargy, maybe some poor feeding. Okay. This can occur without clinical manifestations, but really we will start to see that they are feeding poorly or they're just very sleepy, and that's when we would assess their blood sugars. Okay. We want to try to fix this with feeding before more invasive procedures are started. Okay, so we're not going to jump to starting an IV and really implementing big things. Okay, we want that baby to eat first. Okay, another way that we're going to try to prevent hypoglycemia is to encourage those early and frequent feedings. Okay, they need to be eating every 2 to 3 hours to maintain those levels. Some lab and diagnostic tests. So the universal newborn screening is done on all babies born in the hospitals. It's aimed for early detection of genetic diseases that can result in some severe health problems if not treated. This includes the newborn hearing screen, screening for critical congenital heart disease, and PKU, congenital hypothyroidism. It tests for multiple problems. Okay, we want to detect those early on. Venipunctures. This is something that you guys may or may not get to see. They don't typically do them very often in the newborn, but sometimes they do. Heel sticks. This is going to be important. I've seen this come up on HESI before. You need to be familiar with where to give a heel stick in the newborn. Okay. We want to take a heel stick on the outer aspect or the side of the heel, okay, to prevent any trauma. We can hit the bone, and if we hit the bone, we can cause that baby to have osteomyelitis. Okay. You'll see your nurses apply heat before taking a heel stick in a newborn to help dilate the vessels in the area. So in this picture right here, this baby most likely has a heat pack underneath his little bandage to get that area warmed up. So a way to remember how to do this, you'll draw an imaginary line from between the fourth and the fifth toe and parallel to the lateral aspect of the foot. Okay, so from right there, as you can see down on that very bottom part is where we're going to do the heel stick. Okay, this is also in your book, figure 2312 on page 583. So make sure that you're familiar with doing a heel stick in the newborn. IM injections, we do these in the newborn when we're giving our Hep B vaccines and also vitamin K. You need to be aware that we cannot give more than a half an ml in these babies because their muscles cannot tolerate. Okay, so if we're having to give anything larger than a half an ml, we're going to have to give 2 separate shots in different muscles. Okay. Typically in the baby, we use that vastus lateralis just because it's the largest vessel in the baby. Okay. Circumcision, I don't go super in depth on this. You guys all do it on your nursery prep. Just know that it is a parental decision. We can use some anesthetics. It's 99% of the time we use some sort of anesthetic. It's very important for us to educate mom and dad for care at home. And that care at home box is on page 588. So make sure that you review that and ensure that you would be able to educate a mom on circumcision. If you were to be asked a question on your test, what are you going to tell mom? So we need to make sure that we monitor for bleeding, monitor urine output, and teach that mom how to keep the area clean when changing the diaper and how to wash the area. The last thing for chapter 23 is going to be the CRIES pain scale because we do know that that baby still has pain. Okay, they still experience pain, they just can't verbalize it to us. The CRIES scale is on table 23.5, page 590. So when we are assessing CRIES scale, we look at if the baby is crying, if they require O2 to maintain a level of greater than 95%, increased vital signs, looking at their facial expressions, and then also if that baby is sleepless. Okay. There are different things that we use to help with pain. So some non-pharmacologic is going to be swaddling, non-nutritive sucking, so giving them that pacifier. And we can also use that sucrose, okay, the little vials that you might have seen that have oral sucrose for that baby. Okay. We can also give like acetaminophen and other things, but those babies are usually a higher risk and are typically in the neonatal ICU. Okay. So the nurse administers vitamin K to the newborn for which reason? So the answer for this is going to be C. So the bacteria that synthesize vitamin K are not present in the newborn's intestinal tract. All right, chapter 24. This one is all about nutrition and feeding. I've cut a lot of this out of that chapter, so please make sure you review the outline and go by what we talk about in this lecture. Okay, so just some recommendations. I'm not going to test you guys on this, but I just think it's good information to kind of have an idea of what our expectations are for these new mothers. So the American Academy of Pediatrics recommends that infants are exclusively breastfed for their first 6 months of life. We want to continue breastfeeding for at least 12 months and even longer if desired. And they also recommend that foods are introduced about 6 months of life. Some moms make that decision that they do want to breastfeed, other moms don't want to breastfeed, and we just have to, as healthcare providers, respect that mother's decision and what she feels is best for her baby. So let's talk about lactogenesis, or the anatomy and physiology of lactation. So lactogenesis occurs from a decrease in progesterone after delivery. That decrease in progesterone is going to trigger prolactin to be released. It is a supply meets demand system. So if that mom is breastfeeding frequently, her body is going to respond and continue to produce milk. That's why if we don't want to breastfeed, we don't want to stimulate or allow that mom to produce milk because she's going to try to meet a demand. Okay? So oxytocin is responsible for the milk ejection reflex, or the MER, and also the letdown reflex. It causes the myoepithelial cells around the alveoli to contract and send milk forward through the ducts. So the milk ejection reflex happens in response to thoughts, sounds, cry. So that's why they know when their baby cries that the baby is hungry, and they'll have that letdown reflex. Okay. Some benefits of breastfeeding. This is all in table 24.1 on page 606. So breastfeeding is going to help decrease the risk of postpartum hemorrhage. It also decreases the risk for infection in the infant. It's convenient. We don't need any bottles for breastfeeding, and it's also less expensive. There are some contraindications where we cannot allow the mother to breastfeed, such as if she has active TB or HIV, or active herpes lesions, just because of the risk of transmission to that baby. Signs of effective breastfeeding is going to be in box 24.2, page 618. We're going to talk about that in just a minute. So here is that effective feeding and education that I talked about. Make sure that you review that box 24.2, page 618. So some signs of effective feeding is, the number one is going to be the lochia. So in the immediate postpartum period, we should see a decrease in lochia while that mom is breastfeeding, because remember, it stimulates oxytocin production, and that oxytocin is going to cause contraction of that uterus. When we're talking about the infant, we want to look at their urine output. So we talked about that we want 6 to 8 wet diapers by day 4. So if that baby is having 6 to 8 wet diapers, we are effectively feeding our infant. And then the changes in stool that we discussed, the changes in the color and the consistency as they are eating. Warming milk, this is not really in your book, but it is something that has been on HESI before. So just a little HESI hint, when warming milk, do not put it in the microwave. Whenever you think about if you put some water in the microwave and heat it up, the outside or maybe the bowl or just the outer portion of the water is warm and the center is cold. Therefore, you could think that it's warm and it could be cold, or vice versa. You could think that it simply feels warm and the inside is scalding hot. Okay, so absolutely do not put milk in the microwave. It needs to be done in warm water or with one of those fancy bottle warmers that they have these days. So the uniqueness of human milk, it is immunologically active, which means that they do have some components in breast milk to protect against bacteria. The colostrum is high in antibodies and protein. However, it's lower in fat than mature milk. So that's why colostrum is great in those first few days where we don't need much, but we also need extra antibodies. And then it transitions into mature milk, which has the higher fat contents that the infant needs to grow. Nutrient needs. Don't focus on memorizing these specific numbers. I just think it's really cool to see how by day 1 that stomach can only hold 5 to 7 mLs at a time. By 2 weeks old, we're holding anywhere from 80 to 150 mLs of content at one time. So it's important to realize that those babies in the first days when they're getting small amounts of colostrum, it is plenty to help that baby continue to grow. It's enough nutrient. By 2 weeks, we should be ensuring that they're getting 80 to 150 mLs per feeding so that we're ensuring that they're being effectively fed. Infants do not need water, so we don't ever feed a baby just a bottle of water. And we do expect weight loss in the first few days from fluid loss. So we want it to be less than 10%, okay? Greater than 10% loss in weight is more concerning. Each doctor is going to treat it differently, but for a rule of thumb, we don't want the weight loss in the first few days to be any more than 10%. All right, care management. Each of these, we've kind of talked about these throughout the class, so I'm quickly going to go through each of them. We've talked about engorgement whenever the breasts become firm, tender, or hot from inflammation of the ducts and higher levels of milk production. Treatment for engorgement includes ice packs, cabbage leaves, frequent feedings every 2 to 3 hours. If they're not feeding, they need to be pumping. And then we can also give anti-inflammatory medications. Sore nipples, correct positioning, so that baby is not latching appropriately, so we need to look and see how we can get them to latch better to prevent the sore nipples. Insufficient milk supply, this happens because of the supply meets demand usually. So we need to correct that. We need to frequently empty the breast. Again, if we're not feeding every 3 hours, we need to at least be pumping and trying to stimulate the milk production. We can also increase skin to skin time, and sometimes it's dietary changes. There are different medications possibly that are hampering the milk supply. And so the mom just needs to step back and look at the different changes that she's made in her life and possibly quit taking a certain medication or make a change to her diet that increases her milk production. Plugged milk ducts. This is when an area of the breast becomes swollen and tender. The area doesn't empty when feeding or pumping, so it's plugged. To help this, we want to apply a warm compress to that affected area before feeding, and we also want to frequently feed to keep that milk production going. And then lastly is mastitis, inflammation of the breast. Remember, with this, we want to ensure that they're frequently pumping or feeding their baby. We treat them with antibiotics. but it is important to continue to feed to not have any further issues. We can also use a warm compress before feeding to help with the pain that comes along with mastitis. That is all that I have for chapters 23 and 24. 25 will be uploaded in the next PowerPoint slide that I post.